My name is Rachel Gottbaum, and you're tuned into an archive session from the Atrial Fibrillation Summit at CardioCare Live called Rhythm Control, What Therapy for What Patient? We're here with Dr. Gregory Michaud and Dr. Roy John. This session is brought to you by the Heart Rhythm Society and the American College of Cardiology. Dr. Michaud is director of the Center for the Advanced Management of Atrial Fibrillation and serves as principal investigator for several clinical trials assessing the impact of catheter ablation on health outcomes in patients with AF. He is also an associate editor of the AFib Professional website, a joint initiative of the ACC and the HRS on cardiosource.org. Dr. John is an associate physician in the cardiology division of Brigham and Women's Hospital and assistant professor of medicine at Harvard Medical School. Please note the faculty disclosure policy and the disclaimer statement for both the Heart Rhythm Society and the American College of Cardiology. This webcast is supported by a grant from Pfizer, Inc. So, Dr. John, we're ready for you.
Thank you, Rachel. So we plan to present a couple of cases which are illustrative of the usual problems that we have with atrial fibrillation management. And this is our faculty disclosure. And here's a disclaimer from the HRS and ACC. Let me go straight into my case here, which is that of a 64-year-old lady with diabetes, a typical kind of scenario or presentation with mild symptoms, and she's seen by her primary cardiologist who finds her to be in atrial fibrillation with rapid ventricular rates. She's appropriately started on dabigatran, beta blockers, and for increased heart rates, diltiazem for rate control. An echocardiogram is done and shows mild global LV dysfunction in atrial fibrillation, but with normal cardiac valves and a left atrial dimension of 4.7. Because of increasing heart rates or increased heart rates, her carvedilol was escalated to 50 milligrams BID. Now, she was also on a number of other drugs for her diabetes that included Byetta and a number of other drugs, but also an antidepressant which included fluoxetine, and she had a remote history of epilepsy for which she was on toprimate. Clinical examination was rather unremarkable, and the only abnormality was that of atrial fibrillation with a heart rate of 100 at rest. Now, given her symptoms and presentation, this was a 12-lead ECG on presentation, and you can see that she's got atrial fibrillation with very rapid rates, and she's got partial left bundle branch block, but an otherwise unremarkable EKG. And given her presentation, we decided to bring her into the hospital, which is standard practice for this kind of problem, and we placed her on a telemetry bed, loaded her up with sotalol 120 milligrams BID to replace carvedilol, and then externally cardioverted her after she received 3 doses of sotalol. And this is her EKG soon after cardioversion, and you can see that she has sinus bradycardia, but otherwise an unremarkable EKG in sinus rhythm. Because of the sinus bradycardia, we then discontinued her diltiazem at this point, and her sotalol was reduced to 80 milligrams BID. She was observed for another 12 hours, and the following morning her heart rate was 52 beats per minute, asymptomatic, and she was discharged the following day. So her QTC at the time was 439 milliseconds, which is acceptable and within normal limits. Of course, a week later, everything is fine, and a week later she then is just about getting into the swimming pool for some water aerobics when she has multiple episodes of pre-syncope and a frank episode of syncope. She's taken to the emergency room, and you can see that the telemetry monitoring at that point shows what you see on the screen, which is essentially marked sinus bradycardia with PVCs coming off the T wave with short bursts of typical Torsades-Dupont VT due to polymorphic VT resulting from the effect of prolonged repolarization. Now, at this point, her labs were normal, creatinine was 1.2, and the estimated GFR was slightly below normal. The normal for a woman is about 60, and this was below that. Her troponins were negative. She was given intravenous magnesium. The sotalol was discontinued, and a subsequent echocardiogram showed that her ejection fraction was now normal in sinus rhythm. And this is a 12-lead ECG after things were controlled. in the ER, and you can see that clearly now she has sinus bradycardia, but in addition, the QT interval is markedly prolonged, with the absolute QT interval being about 600 milliseconds, and the corrected QT interval well over what is acceptable as normal at 580 milliseconds. So, because of persisting sinus bradycardia, we placed a dual chamber pacemaker into her and programmed her in the DDI mode at 70 beats per minute with a very long AV delay, so she does not pace in the ventricles, yet she received atrial pacing at a rate of 70 beats per minute, and she was discharged on just a beta blocker at that point. Interestingly, during follow-up, she had one episode of atrial fibrillation with rapid rates, for which I added in diltiazem slow release, and since then she's remained completely free of atrial arrhythmias. So she's pretty much done well with this combination of pacing with rate control, and she has fortunately remained in sinus rhythm. So the point of this case was to demonstrate that drugs have their problems, and one has to be very vigilant with how you use these drugs. However, having said that, I think it's important to recognize that antiarrhythmic drugs are almost always the first-line therapy for these patients, and the majority of atrial fibrillation can be controlled on them. So if you look at these drugs, there's the 3 or 4 types of classes of drugs according to the old classification. The class 1 drugs are the sodium channel blockers. Of course, we don't use quinidine or procainamide anymore. Disopyramide probably still has a role in patients with hypertrophic cardiomyopathy. But primarily, we are limited to using flecainide and propafenone in the class 1 group. Of course, class 2 group is just the drugs that control your heart rate with beta blockers and calcium blockers down to class 4. And then, of course, we have the class 3 drugs which prolong repolarization by blocking the potassium channels. And you have sotalol, dofetilide, amiodarone, and dronedrone. Of course, amiodarone and dronedrone has multiple class actions. Ibutyllide, of course, is only available as an intravenous preparation, and vernicalent, which is a new drug that's available in Europe, again as an intravenous preparation. Now, if you look at the effect of antiarrhythmic drugs, these are effective in maintaining sinus rhythm. Following cardioversion of atrial fibrillation, if you did nothing but just leave them on a placebo or do nothing other than just beta blockers, you will find that recurrence rates are pretty high, ranging from 69 to 84%. Whereas if you used one of these drugs, you can significantly lower the recurrence of atrial arrhythmias. And this is a meta-analysis recently published in the Cochrane reviews. And you can see that amiodarone is probably the most effective with an odds ratio of 0.19 compared to control for recurrent atrial fibrillation, meaning it has an 81% efficacy in preventing atrial fibrillation. And the numbers needed to treat one episode of atrial fibrillation is pretty low. Now, if you look at class 1C and dofetilide, they're pretty comparable. But go down all the way to dronedrone, and you'll find that although dronedrone has been actually advertised as one of the newer drugs effective for atrial fibrillation, it's far less effective than amiodarone, despite its structural similarity to the drug. Now, this is data from about 12 years ago, the Canadian trial that compared amiodarone with sotalol and propafenone, and you can see that amiodarone is far more effective than the other 2 drugs. However, having said that, as time goes on, the chances of maintaining sinus rhythm gradually fall off, and that's one of the problems with antiarrhythmic drugs. This slide is really to show you that once you've failed one antiarrhythmic drug, a second antiarrhythmic drug is very unlikely to be effective. And this is data from one of the recent trials of cryoablation versus an antiarrhythmic drug called the STOP-AF trial. And in this trial, patients had to fail one antiarrhythmic drug before they were randomized to cryoablation versus a second antiarrhythmic drug or a higher dose of the first drug that they had tried. And in this one, you could see that cryoablation was far more effective than a second antiarrhythmic drug, which only had an efficacy of about 7.5% at a year, which is a pretty dismal effect. So it just goes to point out that if you fail one drug, the chances of a second drug being effective are pretty slim. Now, let's go back to that case. Why the unexpected turn of events that we saw in that case that we presented? I think first and foremost, you need to understand renal function is extremely important when you actually start an antiarrhythmic drug, especially in drugs that are completely renally excreted, like sotalol or dofetilide. And in this particular patient, her renal function being just minimally below normal allowed the drug to accumulate over time. Despite the fact that we had watched her for 48 hours in the hospital, this drug clearly had a cumulative effect. The second point to make is drug interactions. There's a number of drugs that we don't recognize as being truly responsible for QT prolongation. Fluoxetine is one of them. It can cause a so-called conditional prolongation of QT interval. That means on its own, it may not have a primary effect on the QT interval. But in the presence of other drugs that prolong repolarization, it actually interacts and probably caused excessive effects in this particular patient. Now, there are other risk factors, as you can see. There's female sex, bradycardia, which she had, hypokalemia. Of course, her baseline QT was normal, although we don't know what her QT interval was when she was in rapid atrial fibrillation, because it's often very difficult to measure QT intervals in atrial fibrillation with rapid ventricular rates. Heart failure is the other risk factor for Torsades de Pont VT. So this is a typical example of how multiple small little factors can accumulate and cause a major problem with a drug that's commonly used. Now, once again, I want to emphasize that drugs are important in the management of atrial fibrillation, and this is basically an algorithm published by ACC showing you the drugs that you use for different conditions. In effect, if you look at the left-hand side, in green, you have patients with no or minimal heart disease, in which case any drug can be used relatively safely in these patients. We tend to start off with flecainide or propafenone because these have the least organ side effects. And then on the right three columns, you basically have patients with hypertrophy, coronary artery disease, or heart failure. Now, hypertrophy is important because once you get to an LVH measuring more than, say, 1.2, 1.3 millimeters of septal thickness, there's usually fibrosis and ischemic substrates superimposed, and all these drugs can interact with them. So amiodarone is a recommendation for those patients. Coronary disease patients should avoid drugs like class 1C, like flecainide or propafenone. Now, heart failure, in this country, we have dofetilide, which is commonly used in heart failure, but amiodarone and dofetilide are the main drugs. We should avoid dronabinol in heart failure patients because of the recent studies showing that dronabinol actually increases mortality, going by the PALACE study especially. Now, the European recommendations are pretty similar, except that they don't have dofetilide in their algorithms. But essentially, what they say is that if you have no structural heart disease, any of these drugs are fine. If you have structural heart disease, avoid class 1C drugs in a patient with coronary artery disease. And if you have heart failure, essentially go on to amiodarone as your primary choice. Finally, I wanted to make a point about the role of pacing in prevention of atrial fibrillation. There's been numerous algorithms and studies done looking at the role of pacing to prevent atrial fibrillation, none of which have really been shown to have any benefit. However, if you have sinus node disease like our patient had, atrial-based pacing clearly has benefit in preventing atrial fibrillation and stroke. Now, this is most beneficial if you minimize ventricular pacing, as we did in our patient. So this case just exemplifies a common clinical problem where we treated the patient with the usual medications to try and control their heart rates and their rhythm. And we ended up with an unexpected side effect because of minor little things accumulating and causing a major issue. So we'll get back to this case later and handle questions, and I'll pass this on to Dr. Michaud for the next case.
Thank you, Roy. Our second case actually began back in 2005 when I met a 46-year-old man who'd been relatively healthy except for hypertension, presented for management of atrial fibrillation. He initially had paroxysmal atrial fibrillation for several years, treated with flecainide, followed by sotalol. In this case, he didn't have a problem with the drug from a side effect, but it just failed to control his symptomatic episodes. Eventually, his atrial fibrillation became persistent about a year before I met him. Therefore, his antiarrhythmic drugs were discontinued since they were no longer playing a role, and a rate control anticoagulation strategy was employed. He had stopped exercising because of symptoms of breathlessness with exertion. Importantly, he had no palpitations. He was sent to me billed as asymptomatic. However, if you talk to him, his exercise intolerance was relatively profound. He had gained a lot of weight as a result of an inability to exercise. His blood pressure was a little on the high side. baseline ECG was atrial fibrillation and looked otherwise normal. He was on rate-controlling medications, namely metoprolol, and he was anticoagulated with warfarin with a good therapeutic INR. His cardiac evaluation showed a structurally normal heart, and importantly, he had only mild left atrial enlargement, which may be in part due to hypertension, in part due to having atrial fibrillation for a year. I recommended catheter ablation, and we performed it in September 2005. This involved isolating his pulmonary veins, which is the staple for catheter ablation of atrial fibrillation, and we also ablated to prevent right atrial flutter, which is another common rhythm that coexists with atrial fibrillation. For several months thereafter, he actually had a rough go. He had several episodes of atrial flutter, which became even more symptomatic than his atrial fibrillation were. They became persistent on 2 occasions, and he required 2 cardioversions, the last of which occurred in December 2005. We started flecainide after the second cardioversion, 100 milligrams twice daily, in addition to the metoprolol and warfarin. From that point forward, he had no more symptoms attributable to atrial fibrillation, and screening monitors showed no evidence of atrial fibrillation. He continued his beta blocker, and we discontinued flecainide and eventually warfarin. Over the next 7 years, he's had screening Holter monitors, pulse checks, yearly visits, has had no recurrence of symptomatic or detectable asymptomatic atrial fibrillation. His EKG now, this was last year, looks normal. His P wave looks normal except for a leftward axis and maybe a little right ventricular conduction delay seen in V1. I think it's useful to go take a step back during this case and think about when we're talking about persistent, what do we mean, paroxysmal. In fact, we don't use the word chronic any longer. Chronic is an outdated term we don't use because these terms, when used correctly, give us a much better picture about the patients we're talking about. Paroxysmal atrial fibrillation then, and this is from the consensus statement, lead author Hugh Calkins from Johns Hopkins, and this is the expert consensus statement published in 2012. Paroxysmal AFib is recurrent AFib that terminates within 7 days. So episodes that last less than 48 hours but terminated by cardioversion are also considered paroxysmal. Persistent AFib is anything between 7 days and 1 year. Greater than a year would be considered long-standing persistent. He was right on the bubble between long-standing persistent, maybe barely into that by a few days or months, and persistent AFib. Of course, these are important because the longer we've been in atrial fibrillation, the harder it is to treat. Doesn't matter whether you're talking about drugs or ablation, it's just harder to maintain sinus rhythm. Indications for catheter ablation. So if we think back to my patient, he falls in the blue category here. He had persistent atrial fibrillation. Maybe he falls into the third category. It would be considered a reasonable alternative to medications. Of course, medications in his case really were not doing the trick. We had not tried amiodarone, but he was a very young gentleman, and concern for long-term toxicity there led them not to want to use that drug. Paroxysmal is the only 1A recommendation. Paroxysmal symptomatic atrial fibrillation having failed a class 1 or 3 antiarrhythmic drug is the primo indication for ablation. Persistent is reasonable, and long-standing may be considered. And in this case, it turned out to be a very good choice if you want to consider him long-standing by a few days or months. If you have not failed a class 1 or 3 antiarrhythmic drug, the indications are less strong. So paroxysmal then would become a 2A if you haven't yet failed an antiarrhythmic drug but are still symptomatic. Persistent would be, and long-standing would be considered, and so level of evidence is much less to support that sort of recommendations short of antiarrhythmic drugs. Our insurance companies, at least in Massachusetts, have not been approving that first category of paroxysmal symptomatic AFib, having not failed an antiarrhythmic drug first. I think they're waiting to see more data. Success is also something that if you read papers on success, it's a very strict definition. No recurrence of any atrial arrhythmia that lasts more than 30 seconds. Short-term success would be defined at 1 year, long-term success at 3 years. However, really, clinical success is another important factor when you're talking to a patient. A patient who has, let's just take for instance, say my patient had 1 episode of AFib in the 7 ensuing years after ablation. He certainly would be probably still a pretty happy gentleman. Or even if you just reduce it by 75% in this consensus statement, that'd be considered a clinical success. If we look at patients with persistent AFib like my own, who have failed antiarrhythmic drugs, in this case, these are patients who failed amiodarone, and the black bars represent ablation success, and the white bars represent continued antiarrhythmic drugs and cardioversions. There's really no contest. It's once you've started failing your drug, just like Roy showed with the cryoablation data, once you fail a drug, it's probably not going to maintain sinus rhythm in the future with more drugs. The single procedure success rates you can expect for paroxysmal AFib are about 80% for paroxysmal AFib, a little less for persistent, with an average of 1.7 to 2 procedures. We can approach that same rate. So it's not one procedure success, it's multiple procedure success, but you can get close to that 80%. And some of those patients will still be on antiarrhythmic drugs. And so in summary, I think the important thing is a lot of patients who are referred to us or not referred to us with persistent AFib are still good candidates for ablation. And really symptoms are the main arbiter when we're trying to decide whether to go with ablation or not. The symptoms may not include palpitations. They may be more subtle things that you have to ask your patient about. And in this case, he did not have much atrial disease, had a pretty structurally normal heart. So you would expect him to behave more like a patient with paroxysmal AFib in terms of his response to ablation. Certainly older patients do worse than younger patients, and persistent certainly may take more procedures than someone with paroxysmal AFib. So I think we can, at this point, Rachel, think about taking some questions.
Great, great. Well, I have some to start, and if folks have questions, please type them onto your screen for the doctors. Dr. Michaud, let me start with you. Are there patients in which catheter ablation should be considered first-line therapy for AF? Do we have folks like that?
I think so. So the first type of patient in whom that would be a very good idea is someone who there are a lot of reasons why the initial antiarrhythmic drugs we are thinking about are not safe. For instance, the patient that Dr. Zhang talked about is very limited in the type of drugs she can take. And so, assuming that she hadn't done as well as she did, and maybe a few years from now she won't be doing as well, certainly thinking about catheter ablation because of the danger of antiarrhythmic drugs in a patient like that is the first. There are some patients that just don't want to take antiarrhythmic drugs. They don't feel as well. They simply have read a lot about them and know that there are risks, and they don't want to take those risks. They prefer a curative approach. I think in those patients it's reasonable. I think right now we're fighting a little bit of the battle that we don't have good data. This would be a plug for a study that's ongoing nationally, internationally, called Cabana, where we're trying to evaluate whether some bigger endpoints, not just symptomatic relief, are going to be in play with catheter ablation. Can we make patients live longer? Can we reduce the number of strokes they have in the future by going to catheter ablation earlier rather than later? So I think we need more data to be stronger in our advocacy for ablation as first line, but I think we'll have that data soon.
And Dr. John, I really have 2 questions for you. One is, this case, the case that you presented, would a baseline ECG have predicted this serious arrhythmia with this drug, sotalol?
So that's an interesting question, Rachel, because most patients, when they present with the arrhythmia, they are in atrial fibrillation, and their heart rates can be very rapid. And when the heart rate's rapid, measuring QT intervals are not, necessarily easy or accurate. If the heart rates are slow, you can, pretty much look at the QT interval and go by what the QT says. But when you have a very rapid heart rate like this, QT interval measurements are extremely, difficult. and may not predict what happens. That's why we almost always wait until after cardioversion to look at the QT intervals. And if the post-cardioversion intervals are normal, we then tend to leave patients on the drug that they've been taking, which is what we did with this patient, yeah.
And what would you say is the take-home message in that case?
The take-home message is renal dysfunction. When somebody has renal dysfunction, be careful with the drug you use. Now, it's interesting that both the algorithms, both the ACC and the European algorithms that I showed for different drugs for different diseases, does not include renal dysfunction as in the algorithm. This goes to show that guidelines are not always necessarily, strict. They're just guidelines. So renal dysfunction is a very important factor, and you have to take into account other drugs that the patient is taking. For example, in this particular case, there was another associated drug, fluoxetine, which in itself is not known to cause QT prolongation, but in conjunction with this drug had a problem.
Well, then in terms of the drugs, we looked at amiodarone. It showed to be more effective. And why is it not more commonly used for AFib?
Well, I think that for one thing, in this country, it's not approved by the FDA for the purposes of treating atrial fibrillation, but only for treating serious ventricular arrhythmias. I think there's a reason for that. First of all, there's not a good study that would provide labeling for atrial fibrillation, but also I think many of us recognize that amiodarone has limitations in terms of its end organ toxicities, can cause permanent damage to the lungs, certainly very serious problems with thyroid, occasionally the liver, neurotoxicity such as tremor or subtle neurologic abnormalities. So many of us really, if there are other alternative drugs or perhaps catheter ablation, we would consider using that ahead of amiodarone in young people. I personally consider it as my back against the wall medication, where we really just don't have any other good options and we really need to maintain sinus rhythm in someone.
So essentially you're saying that with younger patients, you're less likely to use it, but you might use it in older patients.
Yes.
Okay. Now let's talk about follow-up. If a patient remains free of AFib for 3 or more years after ablation, is it safe to discontinue anticoagulation in the presence of risk factors?
So that's a question that most patients ask frequently. The problem, of course, is that we don't have data to support that or to answer that question correctly, mainly because all we know is that if somebody has risk factors for stroke and they have atrial fibrillation, anticoagulation will reduce the incidence of stroke. We don't know if taking away or reducing the frequency of atrial fibrillation with an ablation does the same. Mostly because although they are symptomatically better, there's a lot of patients who actually walk around with silent episodes of atrial fibrillation that may be relevant for the stroke risk. And this is, again, like Greg mentioned, a plug for the Cabana trial, where they are actually looking at all these issues, where the ablation earlier on in the course of atrial fibrillation will prevent stroke down the road.
And just a last question here, as we have a few minutes. I would like to know what would be the take-home message for your case that you discussed, and we just have about a minute left.
Again, I think that once antiarrhythmic medications have been exhausted and we have catheter ablation as a reasonable option for symptomatic patients, by all means, whether they have persistent or paroxysmal is not really a big deal. If they're pretty free of structural heart disease, we view them the same. And so we would certainly consider doing catheter ablation in patients with persistent AFib, and we've had a pretty good result. That being said, we're also pretty experienced, and I think it's very important to have a pretty extensive operator experience before you're delving into patients with persistent AFib.
Right, so we want to go to somebody who has done a lot of these. Okay, we got that. Thank you both very, very much. Thank you to Dr. John and to Dr. Michaud. And thank you to the Heart Rhythm Society and the American College of Cardiology for bringing you this program. Please explore the many AFib resources available at www.hrsonline.org and also www.afibprofessional.org. This concludes our program.